You are in casualty and you had a patient with thoracic trauma. He is having multiple rib fractures. Can he develop pneumothorax? Probably. And can this simple pneumothorax convert to tension pneumothorax? Possibly. So what can you do? Observe. Observe this patient for at least 48 hours. And if this patient doesn't develop any pneumothorax, or the pneumothorax which is already present is static and is not progressing, then you can discharge the patient. So, how would you decide whether to insert an ICD for a patient with pneumothorax or not? We have a rule for it. If at all, the radial lucency which is present in the X-ray is covering 3 or more rib spaces, or the radial lucency is covering more than 1/3 of the lung area, then you have to place an ICD. This X-ray belongs to a chronic smoker who came to the casualty with complaining of breathlessness. On looking at the X-ray, you can see that the patient is having radiolucency on the right side, which is occupying the whole of the lung. And according to our rule, we have to put an ICD for this patient. And that is what the resident in the casualty did. But the breathlessness did not improve. Neither is the saturation. So, in order to find out what has happened, they did CT of this patient. And in CT, they found that it is not pneumothorax but a condition known as bullous lung disease. So whenever in doubt, you have to definitely go for CT scan to differentiate between pneumothorax and bullous lung disease, because putting an ICD in a bullous lung disease will not relieve the symptoms, rather than it aggravates it by creating a humongous pneumothorax, and it will also lead to the death of the patient. So taking the history of the patient is very vital.